How about, is there any reason to choose between the BTK inhibitors based on comorbidities, organ function?
You mean individual ones?
Yeah, like Ibrutinib versus acalabrutinib in patients with cardiac disease.
I don't think, I don't necessarily think so. I think that what we learned between ASH of 2018 and 2017 or 16, when we saw the early data for acala versus more longer-term follow-up, 40 plus months median follow-up, was that some of the same AEs that were present for Ibrutinib were present with acala, again, maybe at a less frequency, but I don't think that you could say to a patient, I don't want you to have a fatal bleed, therefore I'm going to prescribe acalabrutinib, or I don't want you to have AFib or hypertension, therefore I'm going to prescribe acalabrutinib. I think from a clinical standpoint, you couldn't make that argument yet that those AEs are not possible or drugs or not within that particular drug within the subclass. The percent, those AEs were there, they just maybe were less than what we would have expected with Ibrutinib, but then again, it's apples to oranges in terms of patient population, and so I don't really know.
Okay.
I'm a little cautious about doing it for that reason.
So that's a nice segue into, let's delve deeper into the toxicities that we see with the BTK inhibitors. So let's talk about Ibrutinib first. Mm-hmm. What can patients expect? What do you warn them about? Yeah,
so we generally spend a lot of time talking about the AE profile of targeted therapies. We have them meet with a pharmacist as well, in case we forget something. The major toxicities with Ibrutinib that I think about are arthralgias, myalgias, rash, bleeding, bruising, atrial fibrillation or other arrhythmia, infection, and minor GI toxicities. That's sort of the scope of AEs that we deal with when we're using that drug.
Okay, so let me go into a little bit more detail about that. So and I've had these patients myself. Your patient is on full dose Ibrutinib and develops atrial fibrillation, and it's ultimately controlled but still in AFib, or they go back into sinus. Can that patient be rechallenged? Do you stop Ibrutinib? Do you rechallenge? Do you lower dose? What are we supposed to do?
I would only stop it if it's symptomatic AFib. If you're in the office and you feel their pulse and you find their AFib, I really think you could manage them or co-manage them with a good internist or cardiologist or cardio-oncologist, depending on your institution. Very few patients we've had to actually stop because of an AFib event. But it requires management, and somebody has to think about rate control, whether or not rhythm control is warranted, anticoagulation, whether or not that increases the bleeding risk.
Yeah.
I think in the right hands, these patients can be managed. It's not a reason to give up on a good drug, but it does make the situation more complicated. Probably the rate of AFib is somewhere between 5 and 10%.
Do you dose reduce based on that type of AE?
We've tried that. I can't tell you there's any compelling data, either from my own experience or from the clinical trials or the registries or real-world studies that suggest that there are very many dose-dependent toxicities. I can't really say AFib gets better if you're at 280 versus 420. I can't say that about rash. Maybe platelet function, you could argue there's sort of like an aspirin, you're inhibiting platelets based on dose, but I really don't know that does decrease the bleeding risk when you go to a lower dose.
So again, people are looking to you for guidance based on your experience here. In patients who develop atrial fibrillation and they're going to be on long-term anticoagulation, clearly the concern with the Ibrutinib, the BTK inhibitors, is bleeding. Do you use a lower dose of a DOAC, or what do you use for it?
Generally not. We use DOACs for patients. We often then partner with our cardiologist partners to do it. But the risk is stroke, and I feel like making compromises when the outcome is one that's so serious without any data to do that is probably not a great thing for patients. So I really can't tell them what the risk of stroke is on Ibrutinib plus a low-dose anticoagulant. So we try to manage the problems independently if we can, and if it's not tolerated one way or the other, then it's time to switch to an alternate drug that doesn't have that same toxicity profile.
Okay, so what I heard you say then is the major toxicities that I think of with Ibrutinib are atrial fibrillation and the bleeding. That's personally what I think.
Those are the most life-threatening toxicities.
Most life-threatening.
Yeah.
So what I hear you say is those can be managed
Well, the bleeding, if you have a life-threatening bleed, then I don't think that there's a very strong rationale to re-challenge somebody with the same drug.
Okay.
But I think atrial fibrillation could be managed medically as long as, particularly if it's not causing symptoms when it's discovered or minimal symptoms when it's discovered, like they're not in rapid AFib and hypotensive. But if a patient has a life-threatening bleed on Ibrutinib with or without an anticoagulation, I'm a little bit hesitant to try it again. Life-threatening to me means just that.
Yeah.
So then I do think about another drug, a PI3K inhibitor, venetoclax, something that doesn't have a bleeding signal as much.
Okay, I think that's very helpful guidance because you also mentioned maybe a lower dose of a BTK inhibitor might have less platelet dysfunction.
Maybe, but we don't know. I haven't seen aggregometry to support that. But I do think some of the other AEs that are more bothersome but less life-threatening, like arthralgias, we do sometimes stop it, and then I think actually arthralgias is an area where there's still some confusion. I'm not sure that they are all arthralgias. I think early on, sometimes it may be that we're just inducing gout in these people, and that a break in steroids or re-challenging them with steroids gets them through it, or starting at a lower dose gets them through it. I do think that later on it's probably not a gout flare, but it may be the immunological effects of the drug on joints that were injured previously. And there are sometimes we do try different tricks, either lowering the dose or taking a break and then re-challenging. Some people try, glucosamine, for example. I've seen everything reported at least once, these sort of case reports or case series, but I don't think we have a standard of care. Stopping statins is another thing I've heard people do. They all probably work once.
So CLL doctors are becoming like CML doctors, where 10 years ago, with the advent of oral inhibitors that have chronic low-grade toxicities or more serious ones, trying to figure out how to manage those toxicities is important.
It is.
Because otherwise it leads to discontinuation.
Correct.
And you've published on this.
Yes, and I also think probably one of the most under-recognized toxicities within the class is hypertension. People don't feel sick unless they're very hypertensive, and you can have people who have 30-40% incidence of hypertension or exacerbation of an underlying hypertension. It's easy to ignore that. You look at the vitals, they're 148 over 50, 62, oh, I have white coat hypertension. Well, that could be ignored for months. What we don't know is A, what drugs work best on this BTK-induced hypertension, which is real because we know this from the randomized trials, and B, oftentimes the oncologists are hesitant to manage it. We say, go back to your primary. We don't know that that actually happens, and so the long-term vascular, coronary disease, stroke, peripheral vascular disease consequences of hypertension, I think, are unknown at this time. So that's an area where it's a chronic toxicity, but no one feels sick from it, and so that's one of the biggest areas that we're focusing on now.